Thank you for attending today's meeting. Before we get into the meeting proceedings, we are, as we've done for the last several sessions, capturing it on video so we can share the discussion with those colleagues who are unable to attend today, and also we put up a version on the DVA internet site and YouTube. Just a reminder again for people in other locations, could you please mute? Thank you. On the agenda today, as I said, we have 4 presentations set up. One from Alexandra from the Care and Assistance Program section on the Rehabilitation Appliances Program. One from Stephen Clune from the Mental and Social Health Program section to talk about the At Ease portal. One from Rachel Farrell from the Mental and Social Health Program section to give an overview on the new annual Veteran Health Check Program, eligibility and criteria and the tool. And finally from Tanya, our stakeholder engagement manager, to provide an update on what's been happening in her place. Before I begin, before we go to our first presenter, I'd like to also give a quick update on some of the projects and some of the issues that we're attempting to resolve. Now, regrettably, I have to bug out at before 3:30. I've got another meeting about the Productivity Commission report that's suddenly bumped in, and much as I love you all, I do need to go and attend that meeting, so I crave your apology for my early absence. I've already assured Tanya that it's got nothing to do with her.
Sorry, I'm listening to a webinar for work. I'm really sick, yeah. Yeah, it's awful, isn't it? Yeah. It's really bad. Can you hear that idiot at the front door?
We seem to have somebody speaking into their phone.
She's a freaking loser. Like, she's outside and she knows I'm here and she barks at the front door.
Or across line, perhaps.
She's a loser.
Fine.
Oh, yeah, I've been really sick. I could hear coughing there the other day.
Townsville, can I ask you, because I think this is what I've heard and I want to check whether it's heard. Have I heard that Townsville can't actually hear us correctly? Is that right? Can you just wave if I've got it right?
Townsville can hear you, but we're not on the camera.
We're in the black box. You can't see us.
I was going to start taking that face
Right.
Okay.
Yeah, because I nearly collapsed Friday night because I was camping, as you were, and I couldn't put up the tent. I nearly collapsed.
The person talking on the phone, can you hear me?
Yeah, I've taken any of that.
I think that's a completely cross line.
I'm all congested. It's just terrible. Yeah.
I think we can let's hope it's a short phone call and that they're not talking to my mum. Because otherwise it could go on for
and then I was sitting there in my night dress and really bored of friend time. I'm just like, Lily, did you tell me?
To address a couple of things.
To run in and have a chat.
On the single operating model project, it's nearing the end of the project phase.
I can't even talk to anyone on the phone.
The final internal standard operating procedures, which I'm sure you all know, referred to as SOPs, were released by 30 June, and they cover the core steps of the rehabilitation process. So we now have each of our 3 teams working to a common set of procedures and a common set of quality assurance across the 3 sites. The project team will then focus on continuous improvement of the
just doing stuff because you feel like crap.
The fact that we've set up a standard set of operating procedures doesn't mean that they're 100% correct.
Thank you.
And
field testing
is going to flush out anything that
I know, you just feel so
is going
bad.
to flush out anything that isn't working as well as we expected. We'll be implementing the quality assurance program, and we'll be creating over 35 identified support procedures to assist delegates in rehabilitation, such as procedures relating to motor vehicles, childcare and rehabilitation appliances. I say 35 because they're the ones we've identified so far. Over the next 6 months or so of implementation, we'll see what others could emerge. We'll also be working with rehabilitation policy to improve the early engagement for clients transitioning from defence and study. The Rehabilitation Provider Improvement Project, as you would all be aware, from 1 July the new contracts come into effect. If you have any general or specific questions about your agreements, please engage through Tanya or the email box rpip@vva.gov.au. I don't think this is an appropriate forum for us to hold a series of one-on-one conversations about the agreement, but believe you me, if there's anything that you want to address, please do so. We're in the process of engaging a full-time contract manager. We've selected her, but we're thrashing our way through the onboarding process, which is taking a bit longer than we expected. She should come on board in the next couple of weeks and will then be in touch with you all. First of all, just as a relationship exercise, and then for information on the new processes outlined in your contracts, such as the performance conditions. To complete the agreement, the VA is working on new procedural guidelines, which will provide the rules and guidance for providers and consultants in delivering rehabilitation guidelines for DVA clients. A work allocation guideline was issued late in June, and guidelines for initial rehabilitation assessment, plan development, plan administration and plan closure are close to being finalised and will be published. Remaining guidelines will be released over the coming months. We intend to notify by email of new guidelines and associated forms as they're issued. All guidelines will then be reviewed a few months after introduction to make sure that they work in practice. So again, they're living documents, not something set in stone. As part of the new work allocation guideline, which as I said was issued last month, it'll be the DVA relationship manager's responsibility to notify DVA if they can't accept any new referrals. We'll make a note on our internal register to pause referrals, and of course that can be then removed when you put through a request saying that your capacity is improved. So that's the opt-in, opt-out arrangement. One of the things we need to do that is make sure part of our arrangement, one of the critical SOPs on the DVA side is to make sure that there is an equitable allocation of work out to contracted providers. So we need to know if, for the moment, you need to have a pause in so that we don't bombard you with referrals that you're not in a position to take at a particular point in time. And also, we're refining the consultant registration guideline, and I won't try and go into that in detail here, but if you have questions about that, you can take that up in the first instance with Tanya. I said I didn't want to talk about any one-on-one matters relating to the contracts, but I do want to talk about something which has probably affected almost all of you, and that's the issue of late payments. I've only recently become aware of this situation. I think it proves again the value of the stakeholder management position that Tanya provides a direct channel for issues that you might be experiencing back into our sections here in DVA, and we became aware through that channel of serious timeliness issues in processing invoices and a backlog that was affecting many organisations. And I'm also acutely aware for the backlog for some of you extends back to invoices that were presented in April. I don't think it goes further than that. I think March is where it started to become a problem, and exactly why I don't know. But that does mean that some of the smaller agencies have a very large debt exposure from the Commonwealth, which is completely unacceptable, and which we're working to revise. I'm very conscious of the fact that our contract sets obligations to both parties, and one of our obligations is to pay correctly presented invoices by no later than 30 days of receipt of the invoice, and I'm very conscious of the fact that we're not meeting that target at the moment. So whilst I became aware through Tanya of some incidents going back to round about mid-June, 20th or mid to late June, I wasn't aware of that this was a common experience for most providers really until late last week. Just in case you haven't recognised that what I've said to date is an apology, I will make it one. I apologise to everybody for this situation, which is not acceptable. We're working up a process to crunch through that backlog as quickly as possible. Just to explain very briefly, processing of all accounts is done in another part of the organisation. I guess that's not uncommon in large organisations. And they've experienced a number of difficulties, but hadn't until this week made clear to some of the internal stakeholders in the services that they provide the extent of those difficulties. What we're looking at is our ability in my team to stand up a tiger team to process the backlog of accounts. Now, that in turn will take a little bit of time because I've got to recruit people, set up equipment. I have to source that equipment and access through the Department of Human Services. You can understand my pessimism about how quickly that could happen. Once we're up and operating, we think we can knock off the backlog in a month. So, provided that this process is acceptable, somebody might come up with a better idea. You know, we're at that stage at the moment. Here's a way of doing it, and but we would be aiming to have the backlog cleared by the end of August. And if my team is clearing the backlog, then it means the accounts team isn't worrying about the backlog and can process invoices that are being presented from last Monday onwards. Any other approach, I can't see how it would have a risk of just moving the problem down the road, and that's not going to suit us either. Also, what we're investing our effort in at the moment is resolving the backlog, but we also have to make sure that we resolve the systemic issues that caused the backlog in the first place. So that'll be part 2 of the exercise. So again, my apologies that we've placed you in this position. The apologies go to everyone, but I particularly feel for the smaller organisations that do most of their work with DVA, and we're working on a solution. Trust me, I'm from the government. So that was all I wanted to say at this stage. Are there any remarks that anybody wants to make about the things that I've covered in my introduction before we then try and move on to the agenda? Cool. All right, that sounds good. So I'll hand over to our first speaker, Alexandra Keller from the Care and Assistance Program section. Alexandra will be providing an update on the Rehabilitation Appliances Program, which everybody calls RAP.
I have been asked just to ask that everybody puts their phones on mute within the states and territories as well. I think, is it? Oh, there was a little bit of feedback in Brisbane. Okay, so good afternoon. My name's Alexandra Keller. I work on the RAP program, and I've also got a colleague, Gabby, who's in Melbourne, who's also going to assist me. Gabby will answer some of the questions that you might have after I've finished the presentation. So first off, you've also got papers. So today I'll work through those papers. I'll give you a bit of an overview of the RAP program, how it works, how it may be used in conjunction with your rehabilitation plans, and to give you an understanding of the products available on the RAP schedule and how you can access those products for your clients and using the RAP schedule. So I'll start off by saying what is RAP. So it's a Rehabilitation Appliances Program. It's been around for a long while within DVA, and it provides aids, appliances and modifications. So that could be, when we say modifications, they could be minor modifications like ramps and rails to major modifications, which could be a bathroom, for instance. It supports DVA card holders, so those that have gold and white cards, and their families and their carers. It aims to minimise the impact of disabilities, illness and injuries, and helps to maximise the quality of life, independence and well-being. And really we're wanting our clients to participate in the community, and it should facilitate that sort of option. It's governed by treatment principles, and those treatment principles describe the objectives of the RAP program, impose conditions on the supply of items and appliances. So for eligibility for the RAP program, a client must have a gold or a white card, and they must be assessed by a clinical health professional, so whether it be their GP, a specialist, or their GP refers them to an allied health professional. For white card holders, the clinical need must align with their accepted condition. Okay. So I suppose I just want to go through about how RAP is different from rehab, in that clients must have that gold or white card, and that we actually do have contracts with a lot of suppliers, and that makes the ordering of products so much easier for you if you are to access those products, because you're just filling out a direct order form and that goes straight to the supplier, and then that product can be delivered directly to the client. So it can actually make it a much faster process for you. All of the products that are on the RAP schedule are, TGA approved, they're safe, and they're, we obviously get a reasonably good deal with those because they're contracted. Also, our contracted suppliers are very familiar with providing products to DVA clients, and if they are needing to be installed or set up, or they need to have instruction on how to use something, they will also provide that level of basic information as well. Now, under RAP, we actually provide gold card holders with things that are not necessarily accepted disabilities, but they do need to have a clinical need for them, whereas our white card holders must have a clinical need that aligns with their accepted condition. Now, with rehab programs, we understand that you provide products that may come under vocational needs or recreational needs. So you may provide sort of like bedding from a retail bedding supplier, or you may provide exercise equipment. What we're asking is that we've been coming across some of these incidents of late, is that often when people finish their rehab plan, they're wanting a replacement of a product, and if it's not on the RAP schedule, it makes it very difficult for us because they don't align with their accepted condition, or it doesn't align with their card or eligibility. So we'd like you to really look to the RAP schedule, I suppose, in the first instance, if it's at all possible, because obviously once someone finishes on a RAP program, on a rehabilitation program, then it's much easier for us to replace items and things like that. So otherwise we really need to manage the expectations of the clients that once they finish a rehabilitation program, they may not be able to get that product replaced because it may not fit with the guidelines of the RAP program. It may fit with your rehabilitation program, but not with the RAP program guidelines. So that needs to be something that you need to consider when you're working with your client, and you're looking at something that may be a longer term, that they may need that product just for that rehabilitation program, and that might be fine, but it may not be something that longer term they may be able to obtain through the RAP program. And that some of the things that that may be possible for people to access they really do need to link with their war-caused injury or disease or accepted disability would be circular platforms, lifts, guide dogs, vehicle modifications, car hoists, driving assessments in conjunction with vehicle modifications. So those all need to have a clinical need and need to link with their condition. So I'd really suggest that you have a look at the DVA website, have a look at the RAP National Schedule of Equipment. In that Schedule of Equipment, it's quite a large document. It's on as a PDF and a Word document at the moment. We're looking to make it a more accessible document in the future. Where in that document, it details the product categories, who can prescribe that, so the allied health professional that can prescribe that particular product, any special requirements, and any links to any forms or guidelines that you may need to comply with for that particular product. Most items can be ordered directly using the direct order form, and this is sent to the supplier and the product will be delivered directly to the client. In some cases, you'll need to seek prior approval, and it will be stated on there when you do need to seek prior approval. So this prior approval is from DVA, and it's for items that are not on contract or complex aids or home modifications. And there are some products on there that have limits that might be, a price limit, or they might have a limit on the quantity that you can have within a specified time. There are also RAP national guidelines that have been developed to help prescribers when they're prescribing some of those more complex aids, such as adjustable electric beds, assistive communication devices, closed-circuit TV, vehicle modifications, driving assessments, electric mobility aids, home modifications, recliner chairs, stair lifts, and assistive listening devices. Next one just gives you a bit of an overview of some of the products that we do have available on there. So there's thousands and thousands of products on there. So I do ask that you just have an opportunity to have a look at that and see what's available. So review the wrap schedule before ordering any aids and appliances under any other arrangements, because this will make it much faster for your clients, but also we can organise, much faster payment of that as well, so that can all be paid and invoiced to DVA and delivered to them as well. Ensure that your DVA clients have a referral from a GP to the allied health professional, and also that there's a direct order forms. And choose when you're prescribing or you're working with somebody who is prescribing, that you choose the most cost-effective, safe and clinically appropriate product, as you would. Okay, so why would you use the wrap schedule? It gives your clients faster access to aids and appliances. It's the ease of ordering and using direct order forms to suppliers straight away. The ease of supply, and most of our suppliers are familiar with DVA clients, and they know the DVA expectations of supply, delivery instruction, and also it gives you that peace of mind that you've got products that are, meet Australian standards and TGA standards. And it creates an easier pathway for future approvals and supply. Okay. So there's more information. There's a bit of a link there to click into the wrap website, and then there's an email and phone number for you if you were wanting to find out any more, or if you've got any concerns or you want to discuss any of your products or with us, then we're happy to look at that. We do one-off approvals from time to time, but they obviously, they take a bit longer to approve, and we do need to consider those in the breadth of the whole program. Okay, so does anybody have any questions? No?
Just a quick one from Melbourne. Is it quite clearly stated the difference between gold card and white card with what we can and we can't apply for? Because there's no use us putting in an application and find out that they're not eligible.
They do need to have a gold or a white card.
You said earlier on that the white card need must relate to the accepted position. Condition. Okay, thank you.
Sorry.
Seems to be gold.
Yeah.
Okay.
I've got one question. We got a referral the other day for an ADL for a 92-year-old gentleman who needed some basic aids as well as a shower, glass shower taken down and a curtain put in. He was also incontinent, and we've been advised that when we do complex ADLs, they have to be referred to community OTs. So we referred that to the GP to get a community OT. I suggested to our OT to ring the family to see whether a community OT had engaged with a veteran, and there wasn't one in the area. So I'm not sure whether that's a question that I direct to you, but we're finding that we're requested not to do complex ADLs anymore, and they need to go out to community OTs. But we're finding that there's no community OTs out there, so there's a lag time for support for veterans in the community. Do you know anything about that?
Okay. We're going to need to take that. Thank you for the question. It's a very good one. The team responsible for the service delivery of RAP is another one of my teams, but they're not represented here today. So we'll take the question on notice, and as is the case with questions on notice, the answer will be provided in the minutes when they're distributed. So can't do anything today, but we'll do something.
Because we're making recommendations for particular veterans that have safety issues. We're not finishing the assessment because some of the things that are complex, and so the concern for us is they're referred out to the community but not followed up.
Yeah, no, that's an important concern, and we'll address that in the answer.
Thank you.
We have a question in Townsville. We have a question in Townsville.
Okay.
Hi, you just can't see us. So I actually had a client who went in for a surgery. She had a white card and it was an accepted condition. That's why she got the surgery. And then on discharge, the hospital OT recommended like a shower chair and a forward walker just for the post-acute care. And that wasn't approved because she wasn't a gold card holder for some reason, even though that's still her accepted condition. Is that just because it's short term, or is that incorrect? I'm not sure.
It sounds unusual to me. Again,
That's what I thought.
if you can.
So Melbourne's got an answer, guys.
Yeah.
Yep.
Sorry, just to give you a little bit of information about that, there's a rule around the provision of aids and appliances in hospital where wrap equipment is only provided if the item would be required for greater than 30 days following discharge from a public hospital. So if it was a public hospital, that might be why.
It was a private, but regardless, is that the same? So 30 days?
Well, generally from a private, it should be provided. So, I mean, we can follow up why it might not have been, but there is a rule around that.
Yeah, okay. She was just like, it just ended up having to go through the rehab plan and I had to get it all done kind of same day, get it all approved through the delegate. So it was just like, I was just not expecting it to not get approved because it was a post-acute need.
And if it was related to the accepted condition, then that would make sense. Without knowing the details, I couldn't look into it. But again, the contact numbers for the RAP team in that sort of circumstance, that number that's at the back of the slides that you've got, that's a good one to call in that sort of circumstance, just to check in on what's going on.
All right, thank you.
And we'll include a response to those questions in the minutes, so they're there for people to check up on. Something I should have done earlier but didn't in the somewhat discombobulated commencement to the session is remind you about the sort of Q&A system, Pigeonhole. You should have a sheet on your tables about how to about the website to visit and the login to use, and that enables questions to be recorded and makes it more likely that we will provide a response. Alexandra, thank you very much for your work. I'd now like to introduce Stephen Clune to provide us with a presentation on the At Ease program.
Thanks very much. So I'd like to introduce everyone to At Ease, share some of the insights that we got developing it, because I think that could be quite relevant for rehabilitation providers, and then also want to make sure that I can get some feedback and insights from the providers, because I think At Ease in many ways is a digital representation of potentially what rehabilitation providers try and do in the approach that they take. So I'd be really interested in gathering some feedback. As just a starting question, can I have a show of hands if anyone's actually had a look through the At Ease website? Few hands. So I'll do it the other way. Can I have a show of hands who haven't had a look at Ease? Okay. So there is a presentation that you may or may not have. there's a screen grab of at ease, but what might be nice if people do have data on their phone, typing at -ease into their phone and bringing up the homepage might be a good way just to have a quick look at what's on there, because that homepage is a really great way to give an overview of what's there. So on the homepage, the first thing that comes out is that we're helping veterans and their families lead happy and healthy lives. So that's the mission of what we're trying to do with the At Ease initiative. There's two large pictures on there. One is of a family member and the other one is of a veteran, and they're our two target audiences. It's largely around mental health, so there are some specific conditions that we've listed. We know from Google a lot of our traffic comes through into specific pages of the app, so even though we have a nice homepage, a lot of the time people actually skip over that and land somewhere in the website on something around anxiety or PTSD. So people will search, veteran plus PTSD, and they'll come in through At Ease that way. And then we have 4 apps to support the veteran community. One is The Right Mix, which is a responsible drinking app. We have Operation Life, which is for the pointier end of suicide prevention. We have High Res, which is a resilience building app, and then we have PTSD Coach. So Operation Life and PTSD Coach are very much intended to be used with the clinician. So they're not something that we're hoping people just Google and find and download and use themselves, where they're best used by when there's someone seeing a psychologist and guiding them through the use of that. So Operation Life, for example, helps someone develop a safety care plan that you would use if you were presenting into an emergency ward with self-harm. Very similar process. So I think there's a few things I'd like to talk. I'd like to talk a little bit about our target audience and insights, some of the models that we operate on when we're trying to provide the right care at the right time. Most of our users are not actually directly the veteran cohort, so we have majority of our users are family members or professionals. So in that way, we're trying to service those cohorts as well as we can. And I think similar to the rehabilitation providers, from my understanding, is we're trying to move away from this deficit model of you're ill, we need to fix you, to taking a whole of body approach. So I'll step through some of the findings. So the first one is that the majority of our users are not, or there's an assumption that the majority of our users are not the veterans themselves, in that around 2/3 of the users of the At Ease website are female, and the majority of those are under the age of 44, big chunk in 25 to 34-year-olds. So our insight from that is that people are looking at the website on behalf of someone, which is a pretty interesting insight for us, in that we're not marketing directly to the cohort. They're coming in through friend or family. And then the other area of At Ease, which we have an At Ease /professionals area, which provides training for health professionals on understanding the veteran experience. So we've got a lot of resources there to try and help people that are dealing with veterans on a day-to-day basis on their practice to understand what resources are there to help treat the veteran community. So the major finding from that is we've got a young cohort, majority female, and we also have a large portion of the users that are professionals. So in the design of our website, we've tried to reflect that. So on the homepage, the first thing you see is the families, and it's sort of representative because the majority of people that are coming into the website, maybe someone seeking help for someone else, a family member. And the other important area with that is that there's sometimes a perception that the families are the rock that will support the veteran, and from a lot of our feedback, it's from the families in particular, they're like, what about us? How can you help? What's there to help me or my children, so that we're not just the guardian angels that are helping someone, we're also getting some support as well. So a lot of the material is how to help someone else, and also what's available to help and care for yourself, who will care for the carer, because I'm sure most of you know that care is a heightened risk of mental health issues and often suffer from poor health. So major insight on our target audience is, I think, quite interesting, for particularly the high portion of families is really interesting to think about how are they supported. So we follow the step care model. Can I have a show of hands again? Who's familiar with the step care model in health? Few hands. Who's not? Is there lots of people that aren't familiar? Okay, so the step care model is sort of like it's a spectrum of mental health, for example, from most of the population are well, and then we have an at-risk population that might be mildly at risk of mental health issues through to the severe, risky end of ill health or ill mental health, which is where we have some of the things like Operation Life sits in that really pointy at-risk category on the end. So where it's interesting from at ease's perspective is we're trying to support the whole entire veteran community, which it covers that whole spectrum. So the majority of veterans leave defence, or majority of people leaving defence fit into that healthy population. So what's there to be able to support them to maintain good health? What's there for the at-risk community or the mild mentally ill, right down to the severe mentally ill. So the way that our structure is set up is that we're trying to guide people, so no matter where they are on that spectrum of the step care model, there's something that can support them. So we have a Living Well channel, which has lots of information around diet and exercise and being socially connected, which is trying to be like a little bit more fun in saying, here's some stuff that's available to you, to keep you well. We have Signs and Symptoms, which talk about everyday issues that might be affecting somebody. Some of those are to do with mental health. Some of them are to do with life challenges. And then we have a Get Support channel, which is outlining all of the medical care that could be available or areas of where you can go to find care. So that's the step care model is one of our principles that we're trying to position things in and think, okay, how do we support the health of the whole population rather than just focusing on the at-risk population. The third point that I've got here is the role of the trusted advisor, and a lot of the times we think of that as the family, but the other really important area in the veteran community is probably everyone that's sitting around a table in this room or in one of the tables in the States, in that, like OBAS and van officers, really critical to pointing people in the right direction. And I think rehabilitation providers, again, really trusted group of people that that can be that trusted source of information. So we've tried really hard to support the family members to be able to provide them, understand what's available to the veteran community. We're doing a lot for health professionals. And the question that I have is sort of like an open question is what would be, or how could at ease support the rehabilitation providers in that? Is there any existing tools or resources or guidelines that you find as being really valuable? And if there's not, what type of information would help you to support the veteran? And because I think the rehabilitation providers are really similar and probably a lot of crossovers with health professionals in many ways. So we have a whole range of resources there for health professionals understanding the veteran experience, and it'd be interesting. So my email is in the document, Stephen with a ph.clune, C-L-U-N-E. But please, if you have a look through at ease and you have ideas around existing resources that you think these are the go-to sites that I use with a client, or these are the type of resources that we rely heavily on, would be really interested, because I think like there's 100-odd clinicians, 100-odd providers out there working with someone every day. You've got amazing insights. We would be really interested in having a conversation. So feel free to send me an email and start a conversation, because I think your insights would be incredibly valuable to how we can continually evolve and shape at ease. And there's, again, it sort of comes back to family members. I've got some lovely quotes from different research that's happened around the country around family members not having knowledge of what's available at DVA, or how that as a family member they feel like they're outside of that care regime for the veteran, in that all the communication's going to the veteran and they're out of the loop. So an interesting challenge there. So the fourth principle that be interested in sharing is how we've actively tried to move away from this deficit model of like understanding that something's not quite right, therefore here are some tools to try and help make something right, which is really based around something always being wrong, which works in some ways. Like if you can't sleep, it's great. Like you can go, I need help sleeping. There's this thing that's clearly wrong, and there's some breathing exercises that you can do, or some meditation, or a range of advice to help someone sleep better. That's really great, I think, for some particular symptoms. When you move into trying keeping the whole, like the healthy population well, it's a little bit hard. That model doesn't work as well. Like for exercise, just saying, oh, do you not exercise enough? Or are you feeling unfit? Those sort of messages are not as pointing. And so moving to this whole of person approach that takes into account a lot of touch points for the community around their, not just their psychological needs, but their physical needs, social needs, spiritual beliefs, employment. A lot of those, of that content has been, in the last 12 months, we've populated a lot more content on At Ease, which is around physical health, social health. We've got a transition page, which has taken the findings from the transition task force and almost tried to provide a little bit of a self-help guide to some of those areas. And that's one of the areas that I'd be really interested to get feedback from rehabilitation providers on, and like what are the major themes that or patterns that you might see within the veteran community, which there could be some resources put up as a self-help guide to try and say, if this is occurring to you, here's one particular way to try and address it yourself, or here are the organisations in the community that can assist you. So a lot of our referrals from At Ease go to Open Arms, to Relationships Australia, to the sort of trusted government sites or people that are clearly well-established institutions that might help someone if they're facing a particular need. So there's yep. I
was waiting for a natural.
Yeah. No problem.
As I foreshadowed at the beginning of the meeting, I have to bug out early for another meeting. I'll leave you with Mel chairing the meeting and throw back to Stephen in a moment. My apologies again for the disjointed commencement to this meeting, which cost us probably about 10 minutes or so. So, Rachel, it's not that Stephen's been going over it's that it's my poor chairing. So, lovely to see you all again, and we'll catch up soon.
Thank you very much. So, on the very last, or the second last page, there's a transitioning from the ADF to civilian life screen grab that we've got there, and the headings there around. It's probably a nice one to talk to, is how we're trying to refer to someone. So we've got supporting your transition. So underneath that content, we can talk about the Stepping Out program and Open Arms, and that there's Open Arms counselling available to anybody that's served one day in the ADF. The same similar content around finding a new identity. Again, to just point that there's services available. Referencing some of the award winners from the Prime Minister's Employment Awards for finding a new job, to say here are two great agencies that have been recognised for veteran employment by the PM's group. And so for each of those sort of major life challenges, we're trying to point people into some trusted information. But really interested for, again, feedback from the rehabilitation providers. Is there anything in these lists or themes and patterns that are occurring that are not being covered? Like, really interested in what's missing. So my email's in the back. Please reach out if you do have thoughts about what's not included on At Ease, because we work in an agile way and are continually trying to improve the service. So, like, what's missing is often more useful than a pat on the back. So when someone says, I've searched for children and found nothing, it's like, okay, we can add some keywords in there and some content. So that's where it's most helpful. Thank you.
Stephen, just a quick question for Melbourne. You've got a few abbreviations here. I don't know what they are. So,
Yes.
what's a van and what's an MHPE? Because that's a manual handling person in my mind, but I know that it wouldn't be.
Okay, sorry for the shorthand. So a van officer is someone that sits in a DVA office and handles inquiries. Someone in the room would. I'm so used to the acronym, I don't know.
Veterans Access Network.
Okay, thank you. And the MHPE?
Veterans Access Network, CSA is a community support advisor.
Yep.
But they're client-facing staff from DVA that would be interacting with the veteran community. So if you were to ring up someone in one of the Centrelink or go into one of the offices, you'd see one of those staff members. An MHPE volunteer was a men's health peer education
okay, that's great.
network that had a group of volunteers, and they're shifting slightly at the moment, but there's a few people that touch. Yeah, they're all DVA representatives that would engage with the client.
Thank you.
Stephen, you've got a question from Pigeonhole Live. Read that, okay?
So yes, you can. I can confirm that the website has been revamped, and that I think as it stands, it's something that would be good to actively promote to the veteran community. We are moving across to be co-located with Open Arms, so it is something that's going to be integrated into that service in a more coherent fashion over the next period of time. So that they'll have face-to-face counselling and self-help eventually under the one banner. But it is, the website's been revisited, and I think it's it's been getting a lot more traffic over the last 12 months since we've been tinkering with it, which is great. So please, use it.
Thank you. Does anyone from the States have any other questions? No? Anyone from Canberra? Well, thank you, Stephen.
Thank you.
I'd now like to introduce our next presenter, Rachel Farrell, who's the Director of the Mental and Social Health Programs section. Rachel will be giving us an overview of the new annual veteran health check.
Hi, thanks everybody. Just so you can see who's talking. So I'd like to, I won't say necessarily introduce, because we've been doing some soft social media comms of late, which I hope some of you have seen. So the annual veteran health check, it's a new moniker covering 2 health checks. One is the old one-off health check that would all transitioning veterans or veterans who discharge from the military can have one health assessment. The new model is a new program that we've introduced from the 1st of July, where transitioning veterans who discharge after the 1st of July can access 5 years of annual health checks. The intent of that is because we know that often when veterans get out of the military in the first year, everything could be fine. The wheels start to come off in the 2nd, 3rd, 4th year, and that's where we want to try and capture those veterans and support them in whichever way we can. And we thought that a veteran health check by a GP, a comprehensive health check, is one way of achieving that. I might do this separately just to truncate a little bit, because I know how we've gone over time. I've got Medicare, healthcare codes for you. I've got DVA item numbers for you if that's of interest, and I'll send that through separately through the Secretariat. One of the things that is important to note as well is for what we're trying to do with this new project, so the new 5-year project, is we're working with our behavioural insights team inside DVA as well. This is one of their first projects where we're looking at what sort of communications is going to yield the best outcome for the veteran, and by outcome we mean getting them to a health check, because we know sometimes that hard copy letters might work for certain cohorts. Push communications via email or text might work for another, so that's why we're doing a bit of behavioural insights as well. So our communications over the 5-year program may well tweak and change and evolve as we get more and more information. We obviously the uptake right now is zero because it's the 4th of July, and we know that veterans, even if they discharged 3 days ago, they're probably not checking in with their GP right now. So we anticipate not a lot of uptake for the first 9 to 10 months, and then in fact our communications are targeted for that period of time. We've been communicating, as I mentioned, across social media, and as I mentioned, we'll have peaks and troughs with that as well. We've working very closely with defence community organisations and Joint Health Command to capture predominantly those veterans who are still in the military system and haven't yet discharged. So that's where our communications are targeting those. We've also providing ongoing engagement through provider forums such as this, and working with ex-service organisations on around pushing our messaging and making it clear about eligibility. One thing that's really needs to be clear though is at the moment, whilst the new 5-year GP health assessment is only available to those that discharge after the 1st of July, the one-off health assessment is still available to everybody who came before them, or anyone who comes after. So effectively, veterans transitioning after the 1st of July could actually, if they really wanted, grab 6 health assessments, if they could fill their boots. That's the very truncated version of my presentation, but and there's a lot to take in, so open for questions.
Just while people are thinking their questions, I might just actually jump in here because you guys as rehab providers are absolutely at the forefront of this, given that you're getting a client, often they don't have a GP, your first job is getting them engaged, and then you will have the opportunity to actually work with our clients to take up this program. So I'd really encourage you. It might not happen at the INA stage, might not happen at that very first medical case conference, but certainly very shortly after, I'd really like you to think about incorporating just a standard BAU practice, working with clients, do you know this is available? If anybody can make this new program work, it's rehab providers, because you're the ones that are literally holding their hands and taking them to the GP for the very first time.
So just clarify the eligibility for this program. Is that member discharged from 1st of July, is that correct? So prior to then, there's just old program, like is that only once?
That's right, yeah.
Any other questions from Canberra? No? The States, anybody got any questions that they'd like to ask Rachel? Silence.
I would just put it, without harping on again about at ease, I think Stephen's spoke enough for us all, but I would like to say that all the information about this program is actually available on a special landing page on the at ease portal.
Great.
Thank
you.
you.
So much.
Thanks.
Oh, no, sorry, you've got one question.
Oh, how fun.
Through.
2.
Okay, so which is that one? Is there 3 or 2?
2 top.
Okay. So the first question is the annual health check available to veterans who voluntarily or administratively discharge? That's a really good question. It is available to all veterans, regardless of the method by which they left the Defence Forces. However, our Behavioural Insights trial is only targeting veterans who have left voluntarily. We aren't targeting, because we don't want to delve too much into the reasons why a veteran may be medically discharged. So our BI trial is specifically for that. The second question is, do veterans use their white card for their annual veteran health check? Absolutely. And there are, on our landing page for veteran health check, we even have a link back to how to apply for a white card, veteran health card. Yeah, you know what I mean. It's been a long day. Is that the third one? Or? Oh, okay.
Great.
Thank you.
Thank you for coming. So the next item on our agenda is Tanya, and everybody knows Tanya. Stakeholder Engagement Manager update.
Okay. Look, I don't really have an update per se. Obviously, over the last month, I've been speaking to lots of you. I just wanted to share some insights from a separate piece of work that I've been doing, and it's really around some of the things that I've started to see in the initial needs assessments, which we're actually going to rename to initial rehabilitation assessments. But there's just quite a few quality issues across the board that I've picked up that I just thought I might use this time to almost do a little bit of in-service training type things. So I guess the first thing that really struck me, 200 was how many I read. So it is a reasonable sample size now across all jurisdictions. So, and yes, my wine consumption did go up slightly in the last month. The first thing I really noticed was that there was quite a considerable difference in the length and the breadth of the assessments. There were some that were extremely short, where it was pretty obvious there was not a lot of time spent with the client, and then there were others that were at the absolute other end of the extreme. And that might have been for really good reasons, because the client was hard to disengage and you had to actually meet with them for 2 or 3 times. But what I noticed, especially with some of the shorter ones, where there wasn't as much information, there wasn't a contextual statement around, I don't have this information because, the client refused to share it with me, or I felt like if I kept pushing at this stage that the client would disengage. There wasn't that context around it. So I don't know whether it was a case of just an assessment not being done particularly well, or there was a very valid reason for why that initial assessment was very brief, because there was no context around it. So if you could just have a look at that, that would be really good. One of the other major things that really popped out for me was we have headings in there, and sleep and pain, mental health, vocational capacity, but these are meant to be full biopsychosocial assessments, and there was some significant gaps. It was almost like if we didn't have a heading, the issue wasn't addressed. So often I didn't see any comments about drug and alcohol usage, which we know is a significant issue with veterans. Again, it might have actually been done as part of the assessment, but in the absence of any comment to say, Mr. Bloggs doesn't have any drug and alcohol issues, that's all that needs to be in there. We don't know whether you've actually explored that issue or not. So we'll probably have a bit of a look at the template. It's probably not the priority at the moment, but that's something that Mel's team will probably have a look at to really start exploring how we can make that better, because just really reinforcing it is a psychosocial assessment. The other
Tanya,
yeah?
question from Townsville. In the absence of an actual heading, can we just pop that into kind of mental health or social factors? Where would you like that?
Yeah, look, that seems to be the logical place. Yeah, so, it's drug and alcohol, gambling, all of those type of, significant pain, medication abuse, or really any medication abuse. So those would sort of be probably the logical place to put that type of stuff.
Right, thanks.
That's okay. The third thing I noticed was that there was not, in the area where you had the barriers to rehabilitation and the strengths to rehabilitation, I saw lots of lists, but I didn't see a lot of analysis then. What does all of this list of things that you put around what's going to work well and what's not going to work well, there wasn't there for so what? So I think, again, it's really that we're asking for that more context, So the client's got drug and alcohol issues. Why is that going to stop him participating in rehabilitation? Is it because he literally is not functional during the day and therefore can't, attend medical appointments and stuff like that? Or is it the fact that, yes, it's a barrier because he might not be able to, he wants to be a truck driver, but he has such a significant alcohol problem that that's not going to be realistic at this point in time until he gets some treatment. So there are lots of lists, but there wasn't a lot of context. And just the final thing is, for some of them, I then had a look at the plan, and what the information that was in the INA was not always conducive to what was in the plan. And at one of the other, the next session, I'm going to talk about plans in detail, because we would have by that stage released some more information to you around plans and what we expect in plans. But just to really reinforce that now, and the contracts reinforce this, that all of our plans are tailored and individualised. So what we don't want to see is Mr. Blogs engaging with treatment providers as the medical management activity. It now needs to be a little bit more substantial than that. You know, if Mr. Blogs needs a psychiatrist and a physio, it's Mr. Blogs needs a psychiatrist and a physio, not, you know, just he's going to engage with medical professionals. So I'll talk a bit more of that next time, but I did notice that sometimes you read an INA and then you had a very almost generic, watered-down rehab plan, and you're going, this isn't matching up. So,
is there still a 100-character limit on the goals?
Yes, but that's not your problem. That's our problem in terms of how we translate that into ish. So it's you put down there what you think is the quality outcome, and we will sort that through at our end.
Yeah, any more questions for Tanya?
Hang on.
So there'll be a new plan then that you'll release? Because the ones that we have are generic, so...
Yeah, the contract makes it really clear that plans are meant to be tailored and individualised, and we're having a provider, a PPG, that will come out with some more detail around that shortly.
Yeah, we welcome that, individualised plans again. Yeah.
Yeah. Okay, I've got some questions. Can you give an example of new plan expectations that have changed many times over the past few years? So yeah, look, I think I've just answered that, but as I said, at the next session, and even there'll be some opportunities before that, that's something I certainly want to do some work with you on around what are our expectations. And I think that was the only one at this stage. But look, you can always call me, email me anyway, so always happy to take those questions.
Okay, so we're moving on to other business. The only thing I have is the next information session will take place in September or October. Date to be advised, but somewhere around there. Question and answers. Is there anything that we haven't covered today that anybody would like to ask or raise? If not, remember you can always send us, talk through to Tanya and she can answer any questions on our behalf. So finally, thank you everyone for coming. Minutes and a recording of today's session will be uploaded onto the DVA website in coming weeks, so keep an eye out. And thank you.